Good afternoon, everybody. First of all, I want to thank organizer of Balance Cone, especially Dr. Pradeep and Dr. Srinivas. I'm talking about intratympanic treatment of vertigo. Intratympanic drug delivery. It's a direct drug delivery to the middle ear, and drug enter the inner ear through the diffusion from the round window membrane and attain higher intralabyrinthine concentration outer epithelial and have very low systemic side effect compared to the systemic intake of drug. Advantage is that systemic drug attain lower concentration because of low cochlear blood flow and blood middle layer labyrinthine barrier. And round window membrane has compared to labyrinthine ablative therapy, it is less invasive which increases the permeability of general anesthesia and it avoids damage to the membranous labyrinth and cochlea. Drug commonly slide used about anatomy of round window. Round window niche is round window niche is used for intratympanic 3.4 millimeters from the umbo, and it forms an angle of 113.2 degree to the handle of malleus. Round window has three layers: outer epithelial layer, middle connective tissue layer, and inner epithelial layer. And it protects inner ear from the middle ear pathology. And if any middle ear insult occurs, then outer layer become hyperplastic and middle layer become edematous. And round window membrane has ability to transport the macromolecules. The substance which increases the permeability of round window membrane are hyaluronic acid, histamine, and dimethyl sulfoxide. Drug commonly used for intratympanic therapy are aminoglycosides and steroids. Aminoglycoside used for intratympanic therapy are streptomycin and gentamicin, and other aminoglycosides are not used because of more cochlear toxicity. But none of the aminoglycoside have selective vestibular toxicity. Because we use this vestibular toxicity action, the gentamicin damages type 1 hair cell more rapidly and severely than type 2 hair cells, and type 1 hair cells do not regenerate also. The dark cell theory for same, the gentamicin primarily affect the secretory function, and it has a structural and functional alteration of dark cells. And it also improves the ionic dysregulation of endolymphatic hydrops. The indication for intratympanic therapy in miniors when conservative treatment fails, that is use of diuretic, diet restriction, and beta-histine. The review of literature for use of intratympanic therapy in aminoglycoside, streptomycin first introduced by the Fowler in 1948, and Shuknet used in 1956 high dose of gentamicin, high dose of streptomycin, and he used 150 to 600 milligram per day, and till he could see the vestibular symptoms. The vertigo was controlled in 63% of the patients, but all of them, they had profound sensory neural hearing loss. So this result was so discouraging that aminoglycosides were not used in US for almost 2 decades. And the next study was done by Beck and Schmidt in 1970, and he used low dose strategy for the streptomycin, and vertigo was controlled the same, and hearing loss rate was decreased to 15%. The delivery method for intratympanic therapy are intratympanic injections, placement of grommet, and sustained release device like SILVERSTEIN MICROWICK, intra-ear catheter. Intra-ear catheter they put after putting a T-tube and they connect a butterfly connector to it, and fully implanted micropump system. The intratympanic injection we use the tuberculin syringe with a small gauge spinal needle. The SILVERSTEIN MICROWICK, it is placed through the grommet, and the diameter of wick is 1 millimeter and it is 9 millimeter long. The microcatheter is directly placed over the round window, and it is connected to a fully automated electronic pump. The local anesthesia used for the intratympanic injection, a drop of phenol can be used, very popular, and it takes some time to make the eardrum numb, but its effect lasts for few weeks. Commonly used other thing is amla cream, which is a combination of lignocaine and prilocaine, and it takes about 15 to 30 minutes to work. And lignocaine injection can be used, and 10% lignocaine spray can be used. The drug preparation, gentamicin is available in 2 ml vial, and which contains 80 milligrams. So concentration is 40 ml, 40 milligram per ml solution. And those patients who are sensitive to gentamicin, or those who are old patient who are having Meniere's for many years, we can use 20 milligram of solution. This 20 milligram solution or dilution can be done by sterile solution, saline, or we can use buffered solution with bicarbonate. And purpose of this buffer is to prevent the middle ear irritation by adjusting pH. And a small amount of ligno can be used to make the procedure less painful. And the solution used for intratympanic therapy should be kept at body temperature. So if it is a vial is kept in the fridge, we should make it warm before using it. The injection method, it is given by the tuberculin syringe with the 25 or 26 gauge spinal needle. And so solution is injected in the middle ear, and we should use either anterior superior quadrant or anterior inferior quadrant, because posterior quadrant causes more post-procedure giddiness. And middle ear can hold only 0.5 cc of medication, so we should not use entire 1 cc, because the rest will just go through the station tube. The spinal needle is usually, it's difficult to bend, but we can bend it so that syringe will not obscure the view, and solution is left in middle ear for 30 minutes. So we can keep the patient in the reclining position with a 45-degree angle, and can turn head on the side of the injection, so the drug will not clear through the station tube. And after procedure, patient can stand up and can talk, and that will clear the ear from the medication from the station tube. And patient feel exactly same after the procedure. So they can go home on their own. Like somebody is coming driving, he can drive and can go back. And the dizziness after the injection usually starts after a week time. The many dose regimes are suggested for intratympanic therapy. Low dose method, we use a single dose, and one injection is given, and patient is rechecked after 1 month again. And if patient symptoms are unchanged, then we can give the second injection. The titration method, titration means when we check the sign of drug effect, it is called titration. And we check for the spontaneous nystagmus or vibration-induced nystagmus. If patient do not have any spontaneous nystagmus or vibration-induced nystagmus after a week, then medicine is not going to work. Then we can repeat the injection. Weekly regime, when the injection is given weekly, 1 to 6 injections can be given. It may take a week for gentamicin to start work. But it is a slow-acting drug, so a cumulative effect will be there. So if many doses are given, the patient may have it may eliminate the inner ear function, and patient will have significant hearing loss also. So this regime is not used. The complication of intratympanic aminoglycosides are definitely hearing loss. But in many studies done, but in the studies, we cannot differentiate between the hearing loss due to drug or hearing loss due to the natural course of Meniere's disease. If patient is having severe hearing loss due to gentamicin, then it will occur in first 24 hours. Other complication of intratympanic therapy are the pain, tongue numbness, transient dizziness, tinnitus, and patient may have persistent perforation. The acute vestibular deafferentation syndrome, it is a chemical labyrinthine injury, and it usually occurs 3 to 5 days after the injection, and patient have vertigo, nausea, oscillopsia, and imbalance. And we can differentiate it from the vertigo caused by the Meniere's, that symptoms will be progressively worsening for a week time from the time of injection. Then why intratympanic gentamicin may fail, why the treatment may not work? It may be because of wrong diagnosis, it may be a bilateral Meniere's disease, or a drug delivery failure. Drug delivery failure can occur due to round window adhesion. Round window adhesion is seen in 20% of normal population. And if drug is rapidly leaving the station tube, this may be if patient is swallowing immediately after the procedure or yawning, then drug may get clear through the station tube. Or somebody is having a genetic resistance to the gentamicin. Corticosteroid commonly used for intratympanic therapy are dexamethasone and methylprednisolone. Mechanism of steroid, we all know it is anti-inflammatory. It decreases the number of circulating leukocytes, inhibit release of chemoattractive factors, decrease secretion of lipolytic and proteolytic enzymes, and inhibit release of pro-inflammatory cytokines. The many studies are done about this intratympanic use of steroids. First protocol was given by Ito and Scata, and they used 4-5 weekly injections, and they have seen good relief in vertigo in 80% of patients. Another important study is done by Sinoroglu and colleagues, and they used Gromet, and they put 5 drops of 1 milligram per ml dexamethasone on every alternate day for 3 months, and they have seen a good vertigo control in 72% of patients. But another study done by Barr, and here also they use Gromet, and they use dexamethasone for first 2 days and then weekly after that for a month. And they've seen that 86% response in first 3 months, less than 3 months. At 3 months it was 52%, and in 6 months it was 43%. So in their study they concluded that the results with the intratympanic steroid is short lasting. It does not work more than 3 months. One important study done by Shia et al., and they used all oral, IV, and intratympanic dexamethasone, and they also found a good result. The vertigo control in 77%, and hearing improvement also in 35.4% patients. Then, which intratympanic steroid to use, either methylprednisolone or dexamethasone? It is also controversial. Methylprednisolone has a greater binding affinity for the mineralocorticoid receptor, and so it attains high concentration and longer duration of action. But dexamethasone advantage is that this is better tolerated in the middle ear. One important study done by Patel in 2016, whether to use intratympanic methylprednisolone or gentamicin. Here he got almost same vertigo control with both the groups, and but 50% of the patients, they needed repeated injection of methylprednisolone. But speech discrimination score was better with methylprednisolone. Sorry. So this is one important slide where we see that where intratympanic gentamicin, steroid, and vestibular nerve section can be used for many years. So we say that we see steroid injection has minimal hearing risk, but effectiveness is moderate and durability is very less. It lasts hardly 3 months. Best is low dose gentamicin, which is highly effective, and it works for more than 2 years. High dose gentamicin causes significant hearing loss. Labyrinthectomy definitely results in permanent disability. Vestibular nerve section again is becoming more popular, and because hearing risk is less and durability is permanent, but I think it is highly invasive procedure. So conclusion is that it is indicated in the intratympanic therapy indicated in the vertigo patient who do not get improvement with the conservative treatment, and intratympanic steroid and aminoglycosides both have a similar result. Intratympanic steroid can relieve vertigo for 3 months period, and with the steroid the risk of hearing loss is less. And patient with the Meniere's disease who do not experience who experience anxiety and ablative therapy, with ablative therapy, intratympanic steroid is a good option. And for gentamicin, titration method and multiple injections on daily basis is used if the patient is having non-serviceable hearing, because titration method causes more hearing loss. And low dose protocol on monthly basis is a preferred method in the unilateral Meniere's disease. Thank you.
Thank you very much. It's really very informative and valuable presentation. Just I wanted to base attention that sometimes if you got the injection vial from a refrigerator and you did the intratympanic injection, sometimes it causes caloric stimulation. So what we do in our hospital is at least to get sure it's being warm enough Sometimes we put it in all the vial in warm water, or just put in human hands for few minutes. Thank you. Either you put the vial between your hands for keep for few minutes, so it requires a human body temperature. Or we put all the vial gentamicin vial or ampoule, we put it before using it in a warm water for a few minutes. So it doesn't be cold, because if it's cold, sometimes it causes caloric stimulation after the injection. No, we don't use. Yeah, please.